Yes. So a very good morning to all of you. Once again, welcome to Department of Urology, SMS Medical College, Jaipur. Today we have a talk on lower urinary tract calculi, and this will be presented by Dr. GIRRAJ PRASAD and would be moderated by Dr. DHARMENDRA. So I would request Dr. GIRRAJ, come and just start your presentation.
Good morning, respected teachers, my seniors, and my colleagues. Today, my seminar on lower urinary tract calculi, moderator Dr. DHARMENDRA. History. The great Hippocrates said, "I will not cut for a stone, even for patient in whom the disease manifests. I will leave this operation to be performed by practitioners." The history of urolithiasis dates back to the Greek, Egyptian, and the Indus Valley civilization. Describe what may be the earliest known case of lower urinary tract stone disease in a gravesite in Egypt from a 16-year-old boy, approximately 4800 before Common Era. The term lithotomy was coined by Greek Ammonius in 276 before Common Era. The gene CVL is credited for doubling the art of lithotripsy. Etiopathogenesis. In lower urinary tract calculi, bladder stone are the most common manifestation of the lower urinary tract lithiasis. It accounts for 5% of all urinary stone disease, account for 1.5% of urological hospital admission in Western world. The incidence of lower urinary tract calculus like bladder stone or urethral stone is decreased in Western world. In non-endemic area, commonly in adults secondary to disease process, or in endemic area, commonly in children, and mostly primary due to nutritional deficiency and socio-economic condition. Definition. In lower urinary tract calculus in bladder, there are primary stone, they develop in sterile urine, and secondary stone occur in presence of infection like various bacteria, urease producing bacteria, Proteus, Pseudomonas, Klebsiella, outflow obstruction due to structural urethra, benign hypertrophy of prostate, malignancy, neurogenic bladder, impaired bladder emptying or a foreign body, drop down from upper tract. Primary stone most common in children younger than 10 years, peak incident 2 to 4 years, male-female ratio 9:1 to as high as 33:1. Primary stone, mostly solitary stone, ammonium acid urate, calcium oxalate, uric acid or calcium phosphate. In sterile urine, uric acid is the most common, and in infected urine, ammonium acid urate is the most common stone. Causes due to decrease in urine output, alteration in urine pH, metabolic abnormalities, vitamin deficiency, animal protein deficiency. Secondary bladder stone are always associated with an underlying bladder pathology like bladder outlet obstruction of various causes, urethra, benign hypertrophy, prostate, neurogenic bladder, foreign body like suture material, urethral stent, prostatic urethral stent. Uncommon cause like erosion of wire used for circlage and rectal impalement, eroded silk used for dorsal vein complex, migration of brachytherapy seeds, and hereafter clean intermittent catheterization. Long-term catheterization, the incidence in long-term catheterization patient, stone formation occurs 0.7 to 2.2%, retained fragment of vast polyspherule, and migratory drop down from upper tract fail to expel in 3 to 17% of cases. The presentation of bladder calculus, most common presentation, terminal hematuria, and lower urinary tract symptom like frequency, urgency, intermittency, urgent incontinence, abdominal or suprapubic pain, passage of cloudy or sandy urine, pulling of penis in children, pathognomic of bladder stone, and acute, in rare cases, acute urinary retention of urine. Types. Bladder stone is various type. Most common type is mixed stone. They are formed by uric acid and calcium oxalate stone. And single like calcium oxalate stone. Calcium oxalate stone is primary stone, moderate in size, solitary, uneven surface. They have speculation on their surface and dark brown in color. Due to speculation, there is bleeding and dark brown blood spot deposited on surface, so called mulberry stone. Uric acid stone. Uric acid stone mostly occur in gouty arthritis, round to oval in shape, smooth yellow to brown, occur in patient with gout and ileostomy or with bladder outlet obstruction patient. Triple phosphate calculus, composed of ammonium, magnesium, and calcium phosphate, infected urine with the urea splitting organism like Proteus, Pseudomonas klebsiella, grow rapidly, dirty white in color and chalky in consistency. Cystine calculus occur in presence of cystinuria. The defect is defect in dibasic amino acid transparent in GID and renal system. So the presence of cystinuria, radiopaque in radio imaging, high sulfur content. A bladder stone is usually free to move in the bladder. Mucous erosion and hematuria gravitate to the lowest part of the bladder. In clinical feature, men, the incidence of bladder stone is more common in men than women. Frequency, sensation of incomplete bladder emptying, pain, strangury occur at the end of micturition, referred to tip of penis. Pain is worsened by movement. Hematuria, drop of bright red blood at the end of micturition, passage of cloudy sandy urine, and pulling of penis in children, pathognomia of blood bladder. The incidence more in men and less in women because in short urethra in women. So anchoring site is less in women and there is less chance of stone formation. The urine reveals evaluation of urine for investigation, microscopic hematuria and pus or crystal that are typical of the calculus. In diagram, various microscopic crystal are shown like calcium oxalate iodate crystal. They are enveloped and uric acid crystal amorphous. Steroid stone having buffinated crystals and cystine stone having hexagonal crystals. In ultrasound abdomen, the diagram shows a hyperechoic shadow present in the lumen of urinary bladder and post-aquatic shadow and bladder is free to move, so the stone hyperechoic shadow and post-aquatic shadow is changed. X-ray KUV shown radioechoic hyperechoic shadow radioechoic in the lumen of the urinary bladder. Bladder stone in a special scenario like bladder diversion or augmentation. Causes are multifactorial. Persistent bacterial colonization or infection due to infection or inflammatory process. The microimpurities present in the urine. So by the heterogeneous nucleation increased crystal formation and stone formation. Metabolic abnormality like hypercalciuria, hyperoxaluria, hypocyturia. Anatomic or structural factor when ileum colon used for diversion, most common metabolic abnormality is the hyperchloremic metabolic acidosis. And in acidosis, there is decreased calcium absorption and hypercalciuria and stone formation occur. Loss of ileum causes enteric hyperoxaluria, diarrhea, lead to decreased urine volume and lead to stone formation. Bladder stone in urinary diversion or augmentation. Most stone is stomach stone due to infection by the urease producing bacteria, Proteus pseudomonas or Klebsiella. It is due to persistent or recurrent infection of urease producing bacteria. Mucus for bacterial biofilm prevent penetration of antibiotics. Stomal stenosis in conduit, there is stomal stenosis. So the urinary stasis and crystal formation is increased. Poor emptying in continent diversion. If the diversion is continent and there is poor emptying or prolonged urinary stasis, there is increased stone formation. Incidence decrease after shifting from non-absorbable to absorbable suture. Surgery for calculi in urinary diversion require pre-op knowledge of diversion and anatomy. Stone in stomal stenosis require treatment of stenosis because removal of stone alone causing recurrence of the stone formation. Best treatment of these stoma patient is revision of stoma. Stone in protein diversion, the percutaneous approach or AFWL is the treatment model. Small burden of stone in neobladder, the transurethral approach is used. Large burden of stone in neobladder, the percutaneous approach or open surgery is done. Post of management of diversion patient is adequate training with supravenous catheter or small catheter, periurethral catheter in neobladder patient, and for prevention, complete removal of stone, treatment of infection, correction of anatomic abnormality, and prevention of mucus is important to prevent the recurrence of stone formation. Urinary bladder calculi in a spinal cord injury patient. 29% of spinal cord injury patients have bladder stone formation in their life due to complete neurogenic bladder infection. Incidents depend on various factors like level of lesion, severity of injury, persistence of infection, previous stone formation, or method of urinary drainage. Risk of stone formation peak after 3 months of spinal cord injury, and 15 to 30% patients have bladder stone within 10 years. Risk of stone formation quadruple after first stone formation and increasing thereafter. In acute phase, stone formation is due to immobilization, and immobilization causes hypercalciuria and increased chance of stone formation. Urinary bladder calculus in a spinal cord injury patient. In recovery phase, calculi mainly due to persistence of infection. Spinal cord injury patients have increased pH of urine and hypocyturia. Increased pH of urine is due to the infection of various urease producing bacteria. Incidence lower in CIC patient than in indwelling catheter. In long-term catheter patient, there is crystallization of the catheter material and stone formation is in. Prevention of stone formation in these patients include long-term antibiotics, use of ascorbic acid, increased fluid intake, routine bladder lavage, use of silicone catheter. Use of ascorbic acid to make the urine acidic, but excessive acidic acid or ascorbic acid given cause formation of uric acid formation. So take 1 to 2 gram ascorbic acid per day. Bladder stone up to 4 cm treated transurethral by electrohydraulic or laser lithography, and more than 4 cm by percutaneous or open system. Bladder calculi in renal transplant patient. The incidence of bladder calculi or renal calculi in transplant patient is 1 to 1.8%. More common renal calculi, but the bladder calculi formation is also occur due to persistence of infection, persistence outflow obstruction, retained suture material, and various medication like calcineurin inhibitor or steroid. Bladder calculi in renal transplant patient, urolithiasis in transplant patient is 1 to 1.8%, and renal calculi more than bladder calculi. Blood stone incident decrease. USC is the first investigation, and CT for confirmation of the stone. Treatment like cystolithography, laser, or ESW. Treatment of the bladder calculi, non-operative management. The clinical devolution is really like increased hydration and increased urine output, pH maintaining, and when administered properly, renacidin, a solution of citric acid and magnesium carbonate, and may be used to dissolve steroid and calcium phosphate calculi, contraindicated in renal insufficiency. Oral potassium citrate or intravesical administration of alkaline solution can be used for uric acid stone or other acidic stone. Chronic indwelling catheter, acidohydroxamic acid irrigation reduce the incidence of catheter infestation. The acidohydroxamic acid decrease the effectiveness of enzyme urease and decrease the stone production. Treat the cause. If secondary stone present in the bladder and any cause is present, bladder outlet obstruction, foreign body, or spinal cord injury, there is the cause like spinal cord injury patient CIC is when foreign body is removed, or treat the obstruction like structure urethra. Modality of surgical treatment. For surgical treatment, lithotripsy, cystoscopic lithotripsy, percutaneous lithotripsy, suprapubic cystolithotomy, or ESWL is used. Lithotripsy with holmium laser. Holmium laser is mostly used in upper tract calculi, but also used in lower tract calculi. Laser lithotripsy with the holmium laser can deal with large stone. The laser fiber of 200 or 365 micron is used, and 0.6 joule and 6 hertz frequency is used. Lithotripsy with ultrasound. The ultrasound lithotripsy has the frequency of 23 to 25,000, and vibration occur in vertical and transverse direction, and the stone fragmentation occur by lithotripsy. Lithotripsy with pneumatic lithotripsy. Lithotripsy with optical lithotripsy. The optical lithotripsy has a set of jaw of a light piece and eyepiece. Percutaneous suprapubic lithotripsy. If the stone size is large, or it is if the stone size is large, or it is not removable transurethral, the percutaneous suprapubic lithotripsy is done. This is the best method to use if it is not possible to carry out lithotripsy per urethra because of a narrow cystoscopic lithotripsy. These are the transurethral cystoscopic lithotripsy, and stone removed as intact. Suprapubic cystolithotomy. If the stone size is more than 4 centimeter, or the transurethral passage is narrow, the suprapubic cystolithotomy is done by a financial incision, cut the skin and fascia. Chief is cut transversely, and muscle is spread, peritoneum rotated, and bladder open vertically. and stone removed by the Thomson-Barber cystolectomy stone process. Lateral stone management diagram. Lateral calculus. If lateral calculus occur in child less than 4 centimeter, percutaneous cystolithography or more than 4 centimeter, open cystolithography is done. Or in adult less than 2 centimeter and patient having high risk ESWL or less than 2 centimeter and patient is normal. Transurethral access and esophageal cystolithography or 2 to 4 centimeter, percutaneous cystolithography, and if the stone size more than 4 centimeter, open surgery is done. Calculus in urinary reservoir or vesicle augmentation, percutaneous cystolithography or open surgery is the treatment of choice. Prostatic calculi. Prostatic calculi can be either prostatic urethral calculus. Prostatic urethral calculus is always migratory and should be managed as any other urethral calculus. There is increased prevalence of prostatic calculi in patients with pathologically proven benign prostatic hyperplasia. There is no increase in incidence of prostatic carcinoma in patients with prostatic calculi. But the calcification or stone formation increase in prostatic carcinoma or benign prostatic hyperplasia. The majority of prostatic calculi are composed of calcium phosphate due to infection, calcium carbonate phosphate, calcium oxalate, and mixed calcium stone. Prostatic calculi are identified primarily with the use of transrectal sonography and in the evaluation of lower immediate symptoms for prostatic. The incidence of prostatic calculi is increased after 19th century due to increased use of transrectal ultrasound. Plain X-ray films show calculi in 14% of patients. Urethral calculi. Urethral calculi amount 0.3% to 1% of all stone disease. Most common in males. Bimodal age distribution. First peak in early childhood and second peak in the fourth or fifth decade of life. The shorter length of female urethra and the high peak flow rate in adolescent or younger age group may have the protective effect for the younger age group. Most common urethral calculus is secondary more than primary, and most common urethral calculus is migratory. Most common cause of urethral calculus is migration from a bladder or bladder. Urethral calculi with concomitant bladder and upper calculi in 2 to 18% of cases. 98 urethral calculus has a radio oblique and most common in males and basic. The management of urethral calculus, if it is primary calculus, most common infection or steroid, magnesium ammonium phosphate, calcium phosphate, uric acid. Most common is to stricture, diverticulum, hair bearing graft, or brachytherapy seals and cryotherapy. Secondary or migratory more common than primary. Migratory urethral calculi are usually solitary and class than primary. Calcium oxalate is the most common and most common posterior urethral stone than the anterior. Most common presentation of the urethral calculi is painful acute urinary retention from sudden infection of the stone. If able to avoid despite the urethral calculus, deep steam, interpreted steam, or spleen, or cross-mesodian dysuria occur. Posterior urethral stone, perineal, or rectal pain is the most common symptom. Treatment of the urethral calculus is located in the posterior urethra, push back into the bladder or ESWL, or intracorporeal fragmentation. Stones that do not get pushed back into the bladder, in-situ fragmentation using laser or pneumatic lithography should be undertaken. Open cystolithography, the last option in the event of failure of urologic maneuver, open cystolithography for stone in the anterior urethra Do not attempt to push back into the bladder. A smooth surface stone and close to meters, melting the stone out from the meters, and rough and irregular surface stone or large stone in lithotripsy with electrohydraulic or special electroclast. Stone in the postnapulars or distal urethral stone, manipulation with the forceps and anesthesia. Larger and more proximal urethral stone, urethrotomy, and stone extraction, or complicated by urethral structure, urethral cutaneous fistula, simultaneous or stage repair is also done. Trapezial calculus, these commonly occur in adults. A common factor is trapezial calculus is phimosis, low socioeconomic condition, and poor hygiene. The possible cause for trapezial stone are insufficiency of smegma and stresses and salt deposition. These are diagrams showing trapezial calculus and presentation. Most commonly difficult in passing urine. Symptoms include dysuria, hematuria, foul-smelling urine, palpable swelling of calculi. Occasional presentation can be urinary retention. On examination, tight phimosis is encountered. And if on examination there is tight phimosis, also lymph node examination is done to differentiate between the growth and calculus. The treatment of trapezial calculi involves removal of calculi and the inciting cause. In most cases, this requires circumcision and dorsal.
Thank you, GIRRAJ. So we will invite questions from residents and faculty as well. So in the meantime, I'll just give a brief summary. We all know bladder stones and lower urinary tract stones are not that common as renal and ureteric stones are. And the reason probably is the stones are usually formed in the kidney, and if they can pass through the kidney and ureter, they would pass through the bladder and the urethra if there is no obstruction. So most of the stones which can pass through the ureter will pass through the urethra. That's why usually the bladder stones would be less common. Primary bladder stones, the stones which form in the bladder were quite common when we were residents or we were students in children, and particularly in countries like ours and Africa and Middle East. And they probably, the reason behind is the dietary habit. We do not know the exact reason, but the dietary habit would be one of the reasons for formation of primary bladder stones. The other causes for bladder stones, as we know, would be secondary stone formation. If there is an obstruction, distal obstruction, there is a chance of stasis in the urinary bladder resulting in stone formation, like bladder, BPH, urethral stricture, etc., etc. Sometimes the stones can form, as he said, in uncommon conditions, like if there is a history of augmentation cystoplasty, if there is a history of cystocele, if there is associated cystosomiasis, if there is associated, if there is a foreign body, surgery has been done on bladder, etc. The stones can form on those non-absorbable sutures also. A very important cause that we should remember, all residents should remember, that many of our patients are on long-term indwelling catheter, and some of them are on DJ stents also. And we come across so many cases of forgotten DJ stents, which results in encrustation of these DJ stents and formation of stones. And these are mostly calcium phosphate. So when you remove an indwelling catheter, many of the times the catheter bulb can rupture, right? And once the Foley's bulb ruptures, there is a chance that a small fragment of the balloon remains in the bladder and results in stone formation. So it's very important when you remove the catheter, particularly catheter which has been punctured to remove it, and it's not coming out, and you punctured it under ultrasound guidance or rectally. You should be very careful that when you pull the catheter, try to find the whole balloon has come out and there's no fragment remaining. If you are in doubt, you should do a cystoscopy and remove that fragment. Otherwise, there is a good chance of developing stone over that foreign body which remains in the bladder. Similarly, with DJ stents, they may create encrustation and form stones, particularly in the upper part, lower part, because encrustation, renal stones or bladder stones, and that has to be dealt with. All these calcium phosphate stones can be dissolved by 1/4 or 0.25% acetic acid. So you can, so the patients where you see that a lot of phosphaturia is coming, sometimes the catheter gets also blocked due to phosphaturia. So there you can instill 1/4 acetic acid, which will help to dissolve these encrustations and stones. So this was all about, and there are chances, as I said, about some of the uncommon sites like preputial stone, which could be formed if the patient has a phimosis and smegma collection resulting in stone formation. Similarly, there's an uncommon site is ejaculatory duct obstruction. If the ejaculatory duct is narrow, sometimes even with normal ejaculatory duct, you will find stones in the ejaculatory duct, and sometimes seminal vesicles can also form stones, and they will typically present with painful ejaculation. And you can diagnose it by the symptom plus a transrectal ultrasound, which show presence of these calculi in the ejaculatory duct. I think these are very important. About urethral calculi, once there is a urethral stone, you should always push the stone and then fragment it. If there's an impacted urethral stone and you try to incise over the stone and remove the stone from the urethra, there is always a chance of urethral fistula formation. So never incise over the stone in the urethra. Always try to push it into the bladder. If the stone is lying at the meatus, just do a small meatortomy and then pull the stone out. Otherwise, if you try to pull the stone from the anterior urethra or in the glandular region, there's always a chance of damage to the urethra and later a stricture formation. So be very careful when such patients come to you or in emergency. I think this was all about the urinary stones. Dr. Nachi, if you have anything to make a comment, and residents, if you have any queries, anybody? Yes. Yes, so a good question. Again, as he said, there are secondary causes for bladder stone formations, of which one of the most common causes is neurogenic bladder or spinal cord injury patients, where we often find these bladder stones. And often we have found bladder stones after extrafib bladder repair, or even hyperspadias, epispadias repair. If the urethra is narrow, there is chances of bladder formation, bladder stone formation. So as you said about the spinal cord injury patient or neurogenic bladder patients, if you do an open cystolithotomy, there is always a chance of improper healing of the bladder, and there is a chance of leakage from the suprapubic cystotomy site. So you have to be very careful. If there is a large bladder stone and you don't have any other option than to remove it by open surgery, you have to be very careful while after removing the stone. Do a proper 2-layered, 3-layered bladder closure. If possible, put a interposition, or if there is a momentum, just put it and close the abdominal wall very carefully. Still, there would be a chance, and you have to be very careful that there is no obstruction. The patient is either put on an indwelling or a CIC. Yes. Put an SPC. Yes. So again, neurogenic bladder. Yeah, if you put a SPC, there is always a chance of the SPC will not heal once you remove the catheter. So you have to be very careful in patients of neurogenic bladder. Yes. Any other question?
I think there is no algorithm to tell which patient is going to have a bad management in the clinic. But then you have to take your chances because nobody can tell you.
Yes.
But you can just be careful from your end.
So always try to do a non-surgical kind of management, not in that sense that you do boy lithotripsy or cystolithotry or litholepexy, etc. If the stone is very large and it is impossible to do it, then only you take that chance of doing an open surgery, particularly in these patients. And one thing that we said about ESWL in bladder stone, we usually haven't done ESWL in bladder stone, and the most important reason being because in the bladder the stone will move very fast. So it's very difficult to keep the stone focused for shock waves. So one of the ways by which we can keep the stone focused on the shock waves would be to put a kind of a catheter, either a K90 or something, and keep the bladder decompressed. So if you keep the bladder decompressed, there will be a small film of urine around the stone only, and then we can do a lithotripsy. I think that is one of the ways that we can, in our center, also try to do it and see the results of ESWL. Success rate of, have you read about ESWL bladder stone and its success rate? So he hasn't read. I think we should, all of us should go and see what is the success rate of it and how do they do it. This has come into my mind that yes, we can do it in this way. Similarly, if there is a bladder stone and we are trying to do a laser lithotripsy, because it moves very fast, it's not very easy to fragment these stones. One of the ways that you can do is pass a basket, catch hold of the basket, and then pass a cystoscope and do a laser lithotripsy with holding the stone on the basket. So this way you can, I think, prevent this too frequent movement of the stone and help in lithotripsy. Another thing that we can do is, important thing to remember is the different instruments to use for lithotripsy and lithotripsy. He told about the Momai's punch, stone punch, and then there is a visual lithotrite also, which is, so all these instruments are not very kind of safe instruments. You have to be very particular about not damaging the bladder mucosa when you are using these stones, lithotrite or stone punch. So be very careful, otherwise you can cause bladder perforation anytime. Previously, before there were availability of visual lithotrite, we had a blind Thompson's lithotrite, which used to come in different sizes from 1-2 French to the maximum size. Even an infant or a neonate with a stone could be dealt by this blind lithotrite. And we had our senior consultant, who has this blind lithotrite, which is called Thompson's lithotrite, still with him, and he does it wonderfully well. So this is all done only blindly. So there is 2 blades of the lithotrite, by which you just, with the feel of the stone, you pull blindly the stone into the bladder, and then you just rotate the disc, and which causes a crushing of the stone. So this is a beautiful instrument, but can be done only by experts. And because it's almost obsolete nowadays, nobody does it. But I have seen it being done, and it does so well. He does it so well that you just get just like a very crushed stone particles coming out through the bladder after lithotripsy. So all these things are important. As residents, you should remember and learn all these things. And I think if you do not have any other question, I would just wind up this session. So, Dharmendra, if you have something to say about that. So, I think thanks all the residents and faculty members and all those who might have joined us today on Zoom and YouTube. Thanks everybody, and have a good day.